Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the November 13th issue. The first study I'd like to tell you about is the role of CTA in screening for coronary artery disease. Now, we all know that there's no really perfect way to screen for coronary artery disease, and in fact, in a recent study derived from the NCDR database, was found that upwards of 59% of patients who had evidence of ischemia by functional testing did not have obstructive coronary artery disease sufficiently severe to warrant revascularization. So the question really is, can CTA, can coronary computed tomography angiography, serve that purpose, that screening purpose? And to answer that question, the investigators from the CONFIRM registry reported on some 15,000 patients with suspected coronary artery disease, not established, who had been followed for just under 3 years. And what they found was pretty good evidence that CTA is of value. In fact, patients who had no or mild disease by CTA rarely, if ever, were referred for coronary angiography or revascularization, whereas there was a progressive increase in the use of coronary angiography and revascularization as the severity of coronary artery increased. In fact, the vast majority of patients who had three-vessel disease were subjected to revascularization. Of particular interest, what they observed was that patients who had only mild coronary disease, lesions less than 50%, who were revascularized, actually had an increased hazard risk for death, whereas patients who had coronary artery disease with greater than 50% lesions received the benefit. Again, showing the value of coronary CTA not only in identifying disease, but identifying disease that would be benefited by revascularization. Again, a registry, not a perfect study, but evidence that CTA may indeed have a role in screening patients for coronary artery disease. An interesting study in this issue of JACC deals with the question of how renal function, or specifically renal dysfunction, affects the efficacy of spironolactone therapy in patients with congestive heart failure. And this particular manuscript comes from the RAILS trial. I'll remind you that was a test of spironolactone in patients with advanced class 3, class 4 heart failure and ejection fractions less than 35%. And in this particular analysis, they examined the role and efficacy of spironolactone in patients who either had baseline renal dysfunction or had worsening renal function as time went on after the initiation of therapy. And what they observed was, as compared to placebo patients, patients who received spironolactone still had a significant benefit even in the presence of baseline renal dysfunction. In terms of worsening renal function, patients who received spironolactone still received the benefit, but patients who were in the placebo group actually had an increased risk of death with worsening renal dysfunction. That's a 30% reduction of glomerular filtration rate. So clearly, the side effects of spironolactone are hyperkalemia and impaired renal function. So one needs to be very, very careful when using this agent or eplerenone in patients with renal dysfunction. Nevertheless, this analysis from RAILS would suggest, if the patients are carefully monitored, that even patients with impaired baseline renal function or worsening renal function during treatment could still receive a benefit from spironolactone. because a sudden increase in sympathetic activity is believed to be the trigger for most of the very serious arrhythmias in patients with long QT syndrome. Beta blockers have been a mainstay of therapy in this disorder. However, it's never been clear whether all the beta blockers are equally efficacious or whether one is more efficacious than the next. Now, to answer this, a group of investigators from Europe combined their experience with long QT syndrome patients, over 300 such patients, and looked at a comparison between propranolol and metoprolol and nadolol. Now, these patients averaged age 14, so they were a younger cohort of long QT patients. What they found were several interesting findings. Number one, the efficacy of beta blockers in terms of preventing breakthrough arrhythmias seemed to be related to the ability to shorten the QT interval, and the beta blockers differed somewhat in terms of their ability to reduce the QT interval. Of greater importance, what was observed was that the rate of serious breakthrough events, cardiac arrhythmic events, in patients on metoprolol was statistically significantly greater than the other two agents, propranolol and nadolol. And based upon these findings, these investigators have concluded that metoprolol probably should not be utilized in patients with long QT syndrome, at least long QT 1 and 2 type syndromes. Now, this is an initial observation. There are some data that would support it based upon the variable of electrophysiological effects of these agents, particularly on the sodium channel. But to me, as a physician, if there's a reason not to use one of the beta blockers rather than another, even if I'm not 100% sure, I'll probably avoid that agent. And in this case, that would be metoprolol for long QT syndrome patients. We thought that this was a particularly interesting issue of JACC, and I sure hope you enjoyed it. For Inside JACC, I'm Tony DeMaria.